Welcome everyone to today's GlomCon. It's the top of the hour, so we'll get started. I'm Dia Waguespack in Houston, Texas, and I'd like to welcome you all. Today, our talk is titled Biopsy or Not Biopsy in Patients with Diabetic Kidney Disease. And we're very excited to have our speaker, Dr. Maria Jose Soler.
Thank you very much, Dia, for your kind invitation. I will not have enough time to cover all of the message and papers that I receive about this talk, so I hope that you will be interested and enjoy how it will go through. These are my conflicts of interest, and if I live in my dream, and someone asks me, should I or not biopsy my patient with diabetes and kidney disease? I will say, yes. And you can complain with me whatever you want, but I will say yes, and I will try to convince you why yes. We do not have any good marker currently for diabetes and chronic kidney disease. We have the best marker for membranous nephropathy, but we are treating patients with diabetes and chronic kidney disease, and we do not know what we are treating. If they have glomerular, if they have tubular, we don't have any ideas. So I'm jealous of the oncologists, because do you think that oncologists treat any patient without knowing the real diagnosis, the real mutation for the patients that have cancer? Never. So I a little bit, jealous of them, because they know which kind of cancer they have, and they directly have a personalized therapy for the majority of them in our ages, not years and years ago. So I will go through a clinical case, histological classification. What do we have now? Should we perform or not kidney biopsy? Guidelines, where are we? Where are we going in the future, and conclusions. As a background, we know that if the patient has chronic kidney disease and diabetes-related chronic kidney disease, for years, the progression of the kidney disease was not that fast. Actually, the name of microalbuminuria changed because people was confused. Is albuminuria big, smaller? So we decided to establish albuminuria degree 1, 2, 3 for our patients with diabetes. But we are happy now because we are having new drugs. And this graph that I showed you before is already old. And with the new drugs that are not all of them included in this nice revision by Dr. Fioretto, you can see how the patient with diabetes and chronic kidney disease has a long years ahead and progress more slower than before when I started nephrology a few years ago. Just kidding. So the one that we also modify is the names. When I started nephrology, people used to say diabetic nephropathy too old, and I agree with a tweet from Professor Glasgow that said that diabetic nephropathy is when you have kidney biopsy of the patient. If you do not have kidney biopsy, you cannot name diabetic nephropathy. So the KDIGO, the ones started to name diabetic kidney disease. But what diabetic kidney disease? What is diabetic kidney disease if you do not know what the patient has? So the last ones, KDIGO in 2022, they decided to name patient with diabetes and chronic kidney disease. That I think that is a really best, is a really better name for that. So what is the clinical case? I will start with a patient, 62 years old, male, type 2 diabetes mellitus, 15 years since the diagnosis, diabetic retinopathy. So as a nephrologist, if a patient has diabetic retinopathy, we will think for sure this patient will have or a high percentage is patients which have diabetic nephropathy and ischemic heart disease. Creatinine 2.4, urinary to albumin creatinine ratio 350, no non-hematuria, and serum albumin normal. We biopsied that patient because at that time it increased the creatinine from 2.4 to 3.6 without any cause. And in this patient, we found diabetic nephropathy. Here we have another patient from our clinic, 62-year male, type 2 diabetes, 2 years since diagnosis, non-diabetic retinopathy, edema in foot and ankle, normal creatinine, urinary albumin.